I will do today is I will talk mostly about prevention of depression. And so I'm very happy to speak here today. It's unfortunate that we couldn't come together to Verona and talk about this. That would have been much more fun. But I think it's still fun to be here and talk about an important subject as prevention. We have to remember that the prevention field is pretty young. And if you really look at prevention trials in people who do not meet diagnostic criteria, and then you look at the incidence after the intervention compared to no incidence, that's a very early, that's very young. The first trial I know was done in the late 1990s. There were a few in the 1990s later, but almost all of them are done in the last 20 years. I did a meta-analysis of preventive interventions with any diagnosis in 2005, and I could include 13 studies, 13. While now, I will show you that later, only for depression, there are 50 randomized trials using this kind of design. So it's very young, but it's also a booming field. There's a lot going on. People are trying a lot of things. And yeah,
sorry, Pim, to stop you. Are you sharing the screen?
Not yet.
Okay, sorry. Go ahead.
Introduction. Yeah.
sorry.
Yes. So what I was saying is that it's a very young field. And we really have to learn a lot about what works and what doesn't work. I will focus on depression because that's by far the best examined field within the mental health prevention field, so to say. And I think we can learn a lot of lessons from those. So what I will try to do is briefly, why is prevention important? Is it effective? And then I will focus on 5 challenges in the field of prevention. And these are difficult, tough questions. So be prepared that we're not there yet, that everything works and that we know what to do and what not to do. So I won't go too deep into this because I don't have the time, but we have to remember that not only the prevalence of, for example, depression is very high, but the incidence is also very high. So if we only focus on treatments, what we actually do is in the treatment settings, we just wait for all these people to get depressed and then we'll treat them. Well, we know that every year, millions and millions of people develop a depressive disorder, and we do nothing to try to prevent that. We just wait and treat them. I think that's a very important reason to focus more on prevention. With all mental disorders, it's also the case that these are the disorders of the working age. So a lot of disorders with a high disease burden, heart disease, cancer, diabetes, they are disorders that people get when they get older. But depression and other mental disorders are the disorders of the working age. And that means that the costs associated with it are huge, especially in terms of lost output. People don't go to work, or if they go to work, they're much less productive than people who are not depressed. So the costs are huge. And we also have to realize that the treatments of depression, they're good, they work, but not in everyone. And if you look at the population level, I will show that now. So there has been this old study by Gavin Andrews in 2004. I don't think there has much been changed since then. But they estimated on a population level what current treatments can do in terms of reduction of the disease burden of mental disorders. And here you see that major depression, that treatments only take away 16% of the disease burden of depressive disorders. But that's in part because people don't get an evidence-based treatment. So suppose that we could give everybody who gets treatment an evidence-based treatment. This would go up to 23% for major depression. But we also know, of course, that a lot of people with depression do not get treatment at all. So suppose that we would be able to give everybody with a depressive disorder an evidence-based treatment. Then our treatments would still not go beyond the 34%. So even in optimal conditions, our treatments cannot take away more than 34% of the disease burden of depressive disorders. The economic argument is really very important to build up mental health services. And this is the study by Dan Chisholm to show that with a return on investments of every dollar you invest in building up mental health care, also in low and middle income countries, that the return of investments is $3 to $5. So, but this is also about treatment, and it happens far too often that we talk about prevention, but in fact only focus on treatments. And really preventing the onset of new disorders is something completely different from treatment, also in depression. So there is a tendency to say, okay, we have mild depression, that's also some kind of prevention. No, it isn't. When people have a mild major depressive disorder, they have a disorder and they need treatment. That's not the same as preventing the onset of new cases of depression. So I won't go into this too deep. I think it's that the prevention is very important because of the high prevalence, the high incidence, the enormous costs, the burden of disease, and the limited possibilities of treatment. We really should focus more on prevention. And I think that the Redefine project really is a very nice example of how that could and should be done. But is it effective? So as I said in the beginning, there is, I will skip this. I already said this. In the beginning, I mean, there is a lot of research on prevention. But what they usually do is they just look at a high risk group and then look at effect sizes. But that's not prevention. If you really want to do prevention trials, you should, like in the Redefine trial, exclude people who meet criteria for a mental disorder at baseline. And then at follow-up, you again do a diagnostic interview to see how many people developed a mental disorder compared to no treatment. And as I already said, we just got I've done several meta-analysis of this, and we just got one, the last one, the most updated one accepted in Clinical Psychology Review. It should be out in a couple of weeks. And we included 50 randomized trials. Most of them are indicated, so people who already have some symptoms, but there is also quite a few selective interventions now, people in high risk groups. We included only one universal intervention, so aimed at the general population or part of that, regardless of whether they have an increased risk. I will show later why that is. There is a very good reason why there's so very little research on universal prevention. It's very heterogeneous, different target groups, different interventions. So we really have to be very careful with integrating these studies. But we did it, random effects model. Some studies excluded people who ever had a depressive disorder. We could look at the proportion of people who had a disorder in the past. We found no association with the outcomes. Almost all studies are done in high-income Western countries. There were 2 in China and 1 in India. Okay, this is what we found. So for indicated prevention, we found an incidence rate ratio of 0.81, meaning that if you get an intervention, the chance that you develop a depressive disorder is 19% lower than when you do not get the intervention. And I will show you later, this is significant. So we significantly reduce the incidence with indicated and with selective interventions. But the numbers needed to be treated is pretty low. That's 19. You have to give an intervention to 19 people in order to prevent one depressive disorder. Yeah, this is the one in India. I was involved in that. I've been involved in several of these trials, but this one is important because as far as I know, apart from the studies in China, this is the only one conducted in low and middle income countries. It was led by Chip Reynolds and Vikram Patel in India in older adults. I showed this one not only because I'm very proud that we got that published in JAMA, but also because it shows that this preventive intervention was focused on subthreshold depression, but it used an internet-based intervention. And so here we did this with a group of David Ebert and Claudia Buntrock in Germany. And we found here a larger effect size with a hazard ratio of 0.59 and the numbers needed to be treated of 6. So I will focus now on so we saw that prevention really is important. There's no doubt about it. It is, preventive interventions are also effective. If you look at randomized trials, we can prevent the onset in some people. But we do have several major challenges in the field. So power, low baseline risk. Should we focus on universal or targeted prevention? The low uptake of preventive services and the lack of resources and implementation. I will quickly go through them because I don't have that much time. Well, one of the most important things when you do research on prevention is that you need very large sample sizes. And I mean, the REDEFINE trial with 1,000 people, I mean, that's a huge logistic operation, very costly. And that's because in treatments, you just look at the reduction of symptoms, and then it's relatively easy to show a reduction of the symptoms. But if you look at incidence of new cases, that depends very much on the incidence rate in the control group. So if people do not get the intervention, what's the incidence rate? And on the horizontal axis here, you see the proportion of incident cases in the control group. And at the vertical axis, you see the number of people you need in order to show a reduction of, in this case, 25% with the blue line or the 50% with the red line. And you see when the incidence rate in the control group is high, then there is not much of a problem. Then you don't need that many people. But when the incidence rate in the control group is very low, then you need huge sample sizes. And that's exactly why universal prevention is very difficult to examine. It's almost impossible. So for example, in depression, the incidence rate in the general population is 1.5 or 2%. If you want to show in a randomized trial that you have reduced that incidence of 1.5% to, let's say, 1%, you can imagine that you need a huge sample size with several 10,000s of people. So that's one major problem for doing prevention trials, that we need groups with high baseline incidence rates. That's also the second point I want to make, that So if we look at our meta-analysis that I just talked about, when you look at the people in the control group, you can also do a meta-analysis of the proportion of people who develop the depression. So we found that in the control group, 25% of people developed a depressive disorder, which is very, very high, by the way. Most risk factors we know for mental disorders have a much lower baseline incidence rate. But probably these people who participate in these interventions, they know that they have an increased risk, and that's why they participate. So then you get this 25% incidence rate in the control group. The intervention groups, there we found an incidence rate of 17%, which is a significant reduction. But if you look at the whole population of participants, this means that still 75% of the people participating in these interventions won't develop a depressive disorder at all. And from the people, and then the people who do develop a depressive disorder, we could take away this 8% difference, meaning that our interventions are effective. But if you really look at the whole population, these effects are really very modest. And that's also this problem of the base rate risk in high-risk groups. That's really one of the big problems in our field. We don't know high-risk groups with high incidence rates. And it's often said that, for example, children of depressed parents are one of these extremely high-risk groups. And there's one study saying that by the age of 20, these children, that 50% of these children have developed the depressive disorder themselves. But from prevention science point of view, that's still not enough. Because suppose that these children develop a depressive disorder between 12 and 20 years of age. That's an average increase every year. That means that about 6% of them will develop a depressive disorder in the next year, which is still, from the logistics of doing prevention science, a real challenge. So there are all kinds of solutions we can think of. We can look at combinations of risk indicators. We can try to improve the effects of interventions. We can focus on multiple mental disorders instead of only a depression. But I don't have the time to go into that too deeply. Completely different subject is the issue of universal or targeted prevention. And so there is a whole debate in the prevention field whether you should look at universal intervention, so to say, or at high-risk groups. And they both have advantages and disadvantages. So universal interventions aimed at the whole population, that's going back to the ideas of Jeffrey Rose, that you have a normal distribution of mental health problems, for example, depression. And if you're capable to shift that normal distribution only a very little in the positive direction, that has a huge effect on the number of people with mental health problems. And these interventions also have the advantage that you don't have stigma, because everybody gets the interventions. And even when the effects are very small, the impact can be large because you reach a lot of population, the large part of the population. Of course, there are disadvantages. I already explained why it's almost impossible to examine the effects of universal interventions on incidence. The benefits for individuals are very small. And especially in the prevention field, we have the problem that the effects are very small. And then when you have some risk of bias in these trials, the exact outcomes are becoming even more uncertain. targeted interventions, on the other hand, they're relatively easy to examine in randomized trials. So if you look at depression, the strongest evidence is in targeted interventions aimed at high-risk groups or people who already have some symptoms. You can identify these people relatively easy, but of course it also has disadvantages. The uptake is usually low. I will come back to that. You reach small populations, and the impact on a population level is limited. And there is no, in the ideal situation, you would say, okay, we focus on both. And that's the only sort of real solution here, of course. Well, another thing is that the uptake of preventive services is usually very low. And I know that because in the Netherlands, we have had for a very long time preventive services offering free indicated preventive interventions for depression to the general population. We had these coping with these depression courses, we have internet interventions, all kinds of preventive interventions aimed at people who do not yet have a full disorder, so to say. But the uptake is really very low. And that's in itself not so strange, because that's not just related to subthreshold depression. We see that also in major depression. So in mild major depression, the uptake of services is also lower than in severe major depression. And if you look at subthreshold depression, the uptake is even lower. Yeah, and that's not so strange to imagine, because people feel that they are not really ill, and they are not really ill because they don't have a disorder, and they don't consider themselves at risk, or they have a preference to handle problems themselves, and they won't go into interventions because of the stigma related to mental health interventions. But there are also issues in the healthcare system. So, for example, GPs often don't know about preventive services in mental health care. So overall, at that time, when we had these preventive services, and we also have data on subthreshold depression in the Netherlands, of the people who had subthreshold depression, only 1% participated in subthreshold depression. And so that's a real issue. I don't have the time to go into the solutions for this too long, but there are all kinds of things you can do about that. So mass media campaigns, make the interventions with a low threshold. You can focus again on multiple disorders. You can adapt them to the needs of the specific populations you work with. Or what I'm very interested in myself is on indirect interventions. You don't focus on prevention, but on daily problems of people. And we know that most people with depression are inclined to participate in these interventions too. So, of course, and then I get back to the last point. I mean, in the general medical community, there is consensus that depression and prevention of depression is one of the major challenges in the next decades. And of course, I was very proud that this paper got accepted in JAMA, but it also indicates that prevention of depression is something with a strong support from the biomedical community. However, it's the it's also clear that depression is one of the major public health challenges for several reasons. But we also know that treatment is under-resourced. And if you compare treatment of mental health problems to treatments of all other disorders, then treatment of mental health problems is not very well resourced, so to say. But if you then look at the resources for prevention, that's only a fraction of what is available for resources for treatment of mental health problems. So, but if you look at policy papers, then prevention is always a problem. I mean, it's always a priority, but there are hardly any resources going into it. Okay, so I will, I will skip this because of time. I already talked too much. But so briefly, I think depression is clearly a major public health challenge. Treatments can only reduce the disease burden to a limited extent. Prevention, the possibilities of prevention have not been examined extensively enough. And that's why I'm also so very happy with the REDEFINE project, because this is a really well-powered, well-designed, randomized trial to further examine the possibilities of prevention. Thank you for your attention. If you want to know more, send me an email or look at my website. Thank you very much.